All right. Welcome everybody to our VIP virtual rheumatology practicum. Today, just a few reminders before we start. The webinar will start on time, so just in a minute or so. And all attendees are muted throughout the webinar. And the moderator, which is me, I'll review their questions at the end and we'll present it to Dr. Zhu. And at the bottom of your screen, there are three options for questions and comments. So the chat, if you just want to make general comments, everybody can see. The Q&A section is specifically for questions for our speakers today. And so the moderators will screen through those questions and address them at the end. And lastly, if you have any tech issues or any other issues, you may raise your hand to notify the host that you need attention, and they will respond to you via chat. And so I would like to take this moment to welcome Dr. Ray Zhu. It's my great pleasure to introduce him today. And just to tell you, my name is Iftisam. I forgot to introduce myself. I am a second-year rheumatology fellow at Henry Ford Hospital in Detroit, Michigan. So Dr. Ray Zhu is an assistant professor in the Division of Rheumatology at the University of Michigan and a physician scientist. His research focuses on the pathogenic role of neutrophil extracellular traps, or NETs, in various of thromboinflammatory diseases such as antiphospholipid syndrome and COVID-19. He has authored some 37 papers, including first and lead authored publications in highly visible journals, including journals such as Science Translational Medicine, Nature Scientific Report, Arthritis and Rheumatology, and JCI Insight. His current research is supported by NIH, Rheumatology Research Foundation, Arthritis National Research Foundation, and Pfizer. And with a great welcome, I will pass it off to Dr. Zhu.
Thank you, Dr. Get. My name is Ray Zhu. I'm assistant professor and a physician scientist at University of Michigan. It's my great pleasure today to talk about a disease that I'm passionate about, antiphospholipid syndrome. Here's my disclosure. Today, I will give an overview of APS, discuss about the current criteria and clinical manifestations, and new developments in APS pathogenesis. I will spend a lot of time on management, and we'll talk about antiphospholipid antibody in COVID-19 in the later part of my talk. So let's start with the overview. Antiphospholipid syndrome is an autoimmune thromboinflammatory condition that have devastating effects on patients and their families. It has an estimated prevalence of 50 cases per 100,000 individuals. It can involve both the venous and arterial circulations. The deep vein of the lower limbs and the cerebral arterial circulations are the most common sites of venous arterial thrombosis. However, any tissue or organ vascular bed can be affected. The other major clinical manifestations of APS are obstetrical. They include recurrent first trimester pregnancy loss, late trimester pregnancy loss secondary to eclampsia or severe preeclampsia. There's a primary antiphospholipid syndrome that occurs in isolation, and secondary APS that is associated with another autoimmune syndrome, such as lupus. Catastrophic antiphospholipid syndrome, which is characterized by clots in multiple small vascular beds and leads to multi-organ failure with high mortality, develops in the small subgroup of patients. And the picture you can see here is actually a real CAPS patient I saw 2 years ago when I was on service with my fellows. How was APS first discovered? In 1906, a German scientist and physician, August Weisermann, developed a complement fixation-based test to detect antibodies against syphilis. It soon becomes apparent that this test can also become positive among a subgroup of people who do not have syphilis, but have lupus or other autoimmune disease. And the antigen that was responsible for a positive Weisermann's test was later found to be a phospholipid-rich compound. It was purified from a cow's heart and thus named cardiolipin. Lupus anticoagulant was described in the 1950s and was found to be prothrombotic. It's often found among patients with a false positive Weisermann's syphilis test. The first official description of APS in the clinical context was by Graham Hughes and Nigel Harris. It was published on Graham Hughes' birthday in 1983 in Lancet. In this paper, they described the lupus patients with anti-cardiolipin antibodies have a strong association with the arterial and venous thrombosis and also positive lupus anticoagulant. Association of anti-cardiolipin and lupus anticoagulant with pregnancy morbidities was later described as well. Anti-beta-2-GP1 was described in 1990s, and the first international APS classification criteria was devised in 1998 and revised in 2006. Current classification criteria for antiphospholipid syndrome is so-called Sydney criteria, which is a revision of the initial Sapporo criteria. It came out in 2006. It requires a positive test of one or more criteria antiphospholipid antibodies. These include anticardiolipin, IgG, IgM, beta-2-GP1, IgG, IgM, or the presence of lupus anticoagulant for at least 12 weeks in the context of either a thrombotic event or certain types of pregnancy complications. And the classifiable APS pregnancy complications include more than 3 pregnancy loss before 10th weeks of gestations, more than 1 late trimester pregnancy loss, or premature birth secondary to eclampsia or severe preeclampsia. International multidisciplinary efforts was initiated in 2016 to develop new APS classification criteria supported by ACR and EULAR. It is currently at the final refinement and validation phase and is expected to be published in the upcoming year. So one laboratory criteria that often confuses my fellows and residents is the lupus anticoagulant assay. So this is a clotting-based functional assay rather than ELISA-based assay. According to ISTH, which is the governing body who makes the official recommendation on coagulation testing, lupus anticoagulant should follow 3 steps. The first step is screening test. So this is the oldest phenomenon that's recognized. So phospholipid is an important substrate of normal clotting. And when you look at someone's plasma that contains antiphospholipid antibodies, you will have prolonged clotting time. And the second part is a mixing test. Remember that these antiphospholipid antibodies function as inhibitors of phospholipids. Thus, if you have someone with a coagulation factor deficiency, if you mix that 1-to-1 with normal patient's plasma, you should be able to dump enough coagulation factors to fix the clotting time prolongation due to factor deficiency. This is a case when someone has a hemophilia and they're deficient in certain factors. When mixed, you get correction. However, if a patient truly have antiphospholipid antibody, then the mixing is not enough to correct clotting time prolongation. The final step is confirmation. This is more specific for the phospholipids. When you dump enough phospholipids, you will suck up all the antiphospholipid antibodies in the samples, then you will correct clotting time prolongation. So these are the things that you need to think about when you interpret lupus anticoagulant tests. Now, there are some important caveats. These are the things that you definitely need to keep in mind. Whenever possible, blood for lupus anticoagulant detection should be collected in patients now receiving any anticoagulation treatments. So this is the most recent ISTH recommendation. The reason for that is that anticoagulation treatments such as Lovenox, heparin, Coumadin, or DOAC can give you a false positive lupus anticoagulant results. Another caveat is testing a lupus anticoagulant during pregnancy. During pregnancy, we can have increased levels of coagulation factors, which can actually interfere with the lupus anticoagulant result. APS may sound easy based on the classification criteria. However, in our daily practice, APS is much more complex. It represents a disease spectrum. You can see patients in clinic with persistent positive antiphospholipid antibody, but completely asymptomatic, or they only have so-called extracriteria APS features, which we're going to talk about in a little bit. You can have various types of obstetric APS patients. You can have APS patients with arterial thrombosis or venous thrombosis, or both. You can have APS patients with both obstetric and thrombotic manifestations. Of course, you can get definitive catastrophic APS patients or probable catastrophic APS patients. So highly heterogeneous nature of this disease makes it a challenging disease to study and manage. So what are the actual criteria APS clinical manifestations? Well, criteria manifestations, namely vascular thrombosis and pregnancy morbidities, are well-known features of APS. In daily practice, clinical presentation of APS is much more complex. There's also many APS patients with actual criteria manifestations, either by itself or in addition to traditional manifestations, such as thrombosis. These actual criteria features include white matter lesions, cognitive dysfunctions, persistent thrombocytopenias, heart valve disease, livedo reticularis or rhythmosis, and APS nephropathy. While traditional antiphospholipid antibodies are good at identifying traditional APS manifestations, clinically actionable biomarkers for non-criteria manifestations are not yet available. To further complicate things, we also have a non-criteria antiphospholipid antibodies. So criteria antibodies are part of the current classification criteria. These are, those three: anticardiolipin, beta-2-GP1, and lupus anticoagulant. Even though they are the most widely used, there are problems of standardizations and inconsistent clinical performance. So several non-criteria antiphospholipid antibodies have been discovered and show promising clinical utilities this past 10 or 15 years. And these include anti-PSPT antibodies, IgA isotypes of beta-2-GP1 and cardiolipin antibodies, anti-domain 1 of beta-2-GP1, APHL antibodies, and also anti-prothrombin antibodies. Among those non-criteria antibodies, I think anti-PSPT is probably the best studied. You can also order this test from Mayo Clinic and also through LabCorp. This antibody targets phosphatidylserine and prothrombin complex. As of this year, there are a total of 18 clinical studies of anti-PSPT antibodies, and all of those studies show that anti-PSPT is a strong risk factors for arterial and venous thrombosis. So hopefully, the new criteria that will come out next year will include some of those newer antiphospholipid antibodies. All right, now let's switch gear and talk about some new understandings of APS pathogenesis. Well, traditional antiphospholipid syndrome was traditionally, APS was thought to be a prothrombotic disease. But recent research into disease mechanism suggests that inflammation is a very big part of APS pathogenesis. So the initial concept of antiphospholipid antibody-associated thrombosis excluded the role of inflammation. So this is the initial preliminary international consensus on APS classification back in 1999. In this paper, you can see it was specifically denoted that thrombosis should not be accompanied by histologic evidence of inflammation in the vessel wall. Well, more and more evidence has accumulated suggesting that intravascular inflammation plays a very, very important role in APS or APL-mediated thrombosis. Now we recognize that antiphospholipid syndrome is actually a thromboinflammatory disease. So perhaps the best study example is complement system in APS pathogenesis. We know that complement activation by antiphospholipid antibody can generate C5a, which induce tissue factor-dependent procoagulant activities. Studies in humans, such as a PROMISE study, show the role of complement in APL-mediated pregnancy complications. And endothelial dysfunction is a key part of APS inflammatory mediator as well. For example, Antiphospholipid antibody can engage with the ApoER2 receptor and cause a reduction in nitric oxide synthesis, producing a pro-inflammatory and procoagulant endothelial phenotypes, and recently recognized heightened type 1 interferon signature among primary APS patients further supports the important role of inflammations in APS. Another important contributors among APS patients and APS pathogenesis, which has receiving increasing attention in recent years, is the role of neutrophils and neutrophil extracellular traps. So I have to talk to you about my favorite cells, neutrophils. They are known for their ability to be the first responders against many types of infections. Neutrophils, as you know, are the most abundant white blood cells in our circulation. As a neutrophil researcher, I'm obligated to tell you that human body produces 100 billion neutrophils every single day. That's a number of the stars you will find in the entire Milky Way. Because these are cells that come kind of pre-armed, ready to go, they can react very quickly. There's this double-edged sword quality to them. They have a lot of very noxious effector mechanism, which if not properly regulated, can cause problems. And these noxious things that neutrophil can do are meant to be happening in the tissue to eradicate some infectious organism. But when they get turned on irregularly in the bloodstreams, a lot of things go sideways. So when neutrophils are activated, they can form neutrophil extracellular traps, and we abbreviate this as NETs. So this was first reported by the Germans in 2004. This is their appearance. So neutrophil can release a network of extracellular fibers, compounds of decondensed chromatins, including neutrophil DNA and high affinity histones, which are covered with antimicrobial enzymes and granular components such as myeloperoxidase, neutrophil elastase. So they're presumed to act as a physical and antimicrobial barrier extracellularly to prevent the spread of infection and use their antimicrobial peptide to kill pathogens. But NETs can also lead to autoimmunities. They expose autoantigens such as nucleic acids and proteins, which can stimulate an autoimmune response in susceptible individuals. Multiple studies have implicated NETs formation in chronic rheumatic process and disease, as seen in lupus, ANCA vasculitis, and also rheumatoid arthritis. It was also reviewed in recent years that these NETs are prothrombotic. There are a lot of ways that NETs cause blood clots, ketonic histones from NETs can activate platelets, endothelial cells. NETs, of course, contains protease, including elastase, and these proteases can degrade antithrombotic factors such as tissue factor pathway inhibitors. And NETs can activate both the intrinsic and extrinsic coagulation pathway. And NETs can also present tissue factors and serve as scaffolding for thrombus formations. So our group was first to demonstrate the association between antiphospholipid antibody and NET release. So we found that circulating NETs levels were increased in APS patients, and the neutrophils isolated from APS patients release more NETs than control neutrophils. And control neutrophils that are conditioned with APS patient serum have a more pronounced NET release compared to those treated with healthy serums. We later also purified the antiphospholipid antibodies from APS patients, and those antibodies can also trigger NETosis directly in donor neutrophils. Furthermore, those APS patients can also have circulating anti-NET antibodies, which makes it harder to degrade NETs. So utilizing a novel anti-NET ELISA, we found markedly elevated levels of anti-NET IgG and IgM in patients with primary APS as compared with the healthy controls. We further proved that these anti-NET can impair NET degradation. So serum from patients with primary APS or secondary APS show impaired NET degradation as compared with healthy controls. Importantly, high levels of anti-NET IgG correlate with decreased net degradation, while depletion of IgG partially restored net degradations. So these data suggest neutrophils and nets definitely plays an important role in the thromboinflammatory medial of antiphospholipid syndrome. Now let's switch gear and talk about what can we do to help manage those antiphospholipid antibody positive and APS patients. So I'll discuss primary thrombosis prophylaxis, secondary thrombosis prophylaxis, and also obstetric management. So first, we'll talk about how to manage patients who have positive antiphospholipid antibody, but they never had thromboembolic events in the past. So before we talk about the best management strategy for primary thrombosis prophylaxis, we need to answer three important questions. First, who is at risk? Second, what is the incident thrombosis rate in antiphospholipid antibody positive carriers? Third, what are the additional risk factors for antiphospholipid antibody-related thrombosis? So who's at risk? Those are the patients with the clinically significant antiphospholipid antibody profiles is at risk. But what does it mean to have a clinically significant antiphospholipid antibody profile? First, antiphospholipid antibody have to be persistently present for at least 12 weeks, and they have to be at moderate to high titer. Low titer and transient antiphospholipid antibody are not considered clinically significant. Lupus anticoagulant, as I discussed with you, is a functional assay. They associate strongly with the thromboembolic events. IgG isotypes associated with more risk compared to IgM and IgA, and triple positive antiphospholipid antibody carriers have a higher thrombotic risk compared to double or single positive antiphospholipid antibody carriers. So among patients with a clinically significant antiphospholipid antibody profiles, what is the incident thrombosis rate? Here, I summarize 4 attempts at answering these questions. The first one was led by Rufati from Italy. They looked at 258 antiphospholipid antibody positive patients. 69% had lupus. They followed them for 4 years, and he saw the annual thrombotic incidence is 1.86%. The second one is done by Pengo, also from Italy. Here, he looked at 179 lupus anticoagulant positive patients and followed for 2 years and found the annual thrombotic incidence is 1.55%. And the next one is also by Pengo, looking at 104 high-risk antiphospholipid antibody positive carriers. Those are the triple positive APL positive patients, and followed them for 4.5 years. Annual thrombotic incidence is around 3.71%. And the last one is from France, and they look at 98 antiphospholipid antibody positive patients. They followed them for 13 years. 78% also have lupus, and they saw the annual thrombotic incidence is 2.3%. So these studies suggest that the annual thrombotic incidence of antiphospholipid antibody positive patients who never had thrombosis is somewhere between 1 to 4%. And the triple positive APL positive patients have higher risk. So what is the second hit thrombosis risk factors among those APL positive patients? And these remains debatable. And the assessment of the additional risk factors is challenging due to the rarity of this disease and the low event rates in those asymptomatic antiphospholipid antibody positive carriers. So here I summarized 4 studies. And the first one is from Padova, Italy, also led by Rufati. He has shown in these studies that hypertensions and the presence of lupus anticoagulant were significantly associated with the thrombotic events. On the contrary, another prospective studies of thrombotic risk among 150 lupus anticoagulant positive patients observed that smoking, diabetes, and prolonged PTT were independent predictors of thrombosis. When looking at high-risk triple-positive antiphospholipid antibody-positive patients, it seems the male sex also combined venous thrombosis risk factors. And these include, history of estrogen exposure and use, pregnancy, malignancy, history of thrombophilia conditions such as protein C, protein S deficiencies, factor V Leidens, and these combined venous thrombosis risk factor was associated with future thrombosis. And the last study is a cross-sectional study done by Savino from Italy. This is a cohort of 211 lupus patients, either have antiphospholipid antibody or not. He found that the presence of hypertension and hyperlipidemia among antiphospholipid antibody positive patients is associated with future thrombosis. So the most importantly, we need to recognize that thrombosis is multifactorial. Non-antiphospholipid antibody thrombotic risk is equally important when we think about primary thrombosis prophylaxis. All right, who's at risk? Those are the patients with clinically significant antiphospholipid antibody profiles. What's the incident thrombosis rate among those antiphospholipid antibody positive carriers? Probably 1 to 4% annually. So what are the additional risk factors for antiphospholipid antibody-related thrombosis? Those are various cardiovascular risks and also traditional thromboembolic risk factors. So what treatment options do we have? First, let's talk about aspirin. Uncontrolled observational studies have favored the use of aspirin as a primary prophylaxis agent among antiphospholipid antibody positive patients. A PLAZA trial, which was done by Dor Erkan from HSS, is the only randomized control trial. So this is a multi-center randomized control trial of 98 patients with a persistently high titer antiphospholipid antibody who were randomized to get either daily 81 milligrams of aspirin or placebo, and they were followed by 2.3 years. It has shown that aspirin has no benefits in primary thrombosis prophylaxis. This is a recent meta-analysis of all aspirin trials in APS, and their results actually slightly favors the use of aspirin. However, it is driven mostly by uncontrolled observations. Recent EULAR guidelines does favor the use of aspirin among antiphospholipid antibody positive patients. I think I want to point it out is even low dose aspirin can increase the risk of bleeding. So when we consider aspirin as a primary thrombosis prevention agent, we really need to weigh in the risk of bleeding before considering long-term use of aspirin in primary prophylaxis among antiphospholipid antibody positive patients. How about hydroxychloroquine? We know hydroxychloroquine is an important agent in rheumatic disease due to its anti-inflammatory, immunomodulatory, and metabolic effects. It also stabilizes the annexing A5 matrix and has protective effects on endotheliums. So Michel Pitre showed a reduction in both arterial and venous thrombosis rate in antiphospholipid antibody positive lupus patients in her Hopkins cohort who received hydroxychloroquine. However, it is not clear if the protective role of hydroxychloroquine against thrombosis in lupus is associated with its effect on antiphospholipid antibody, or its effect in controlling lupus activities, or its effects in modulating the traditional cardiovascular disease risk factors. Uncontrolled observation by Dor Erkan from HSS suggests its benefit. Again, majority of those included patients have underlying lupus as well. HEC trial is a prospective randomized control trial aimed at evaluating the role of hydroxychloroquine in primary thrombosis prevention among primary antiphospholipid antibody positive carriers. Unfortunately, it was terminated early due to low recruitment rate and high hydroxychloroquine price. So at this time, there are no randomized control trial data to support its use. How about stattin? study inhibits the HMG-CoA and therefore upregulate nitric oxide synthase to prevent thrombus formations. In the prospective mechanistic study from UT Medical Branch and HSS, 41 APS patients treated with the fluvastatin for 3 months demonstrated a reduction in pro-inflammatory and prothrombotic biomarkers. It concluded that statin-induced modulation of antiphospholipid antibody effects on target cells can be a valuable future approach in the management of antiphospholipid antibody positive patients. However, no direct clinical trials thus far evaluated the role of statin in primary thrombosis prophylaxis among antiphospholipid antibody positive patients. Well, human mechanistic studies suggest statin may be a useful strategy for primary thrombosis prevention. Further clinical evaluation is definitely warranted among antiphospholipid antibody positive patients, but we do think that antiphospholipid antibody carrier who have other concomitant cardiovascular disease risk factors may be a great candidates for statin medications. How about vitamin D? The central role of inflammations in antiphospholipid antibody-mediated thrombosis underpins the potential of vitamin D in treating APS patients, since they possess numerous immunomodulatory properties. Among its many effects, vitamin D can inhibit toll-like receptor and MADI88 signaling pathway, tissue factor expressions, and also endothelial activations, which makes it an important modulator of antiphospholipid antibody-associated thromboinflammatory risk. Low vitamin D levels correlate with venous and arterial thrombosis in APS patients from observation and retrospective studies. And a retrospective cohort study and meta-analysis of 4 case control studies confirmed that APS patient had an approximately 3 times increased frequency of vitamin D deficiency. Thus, vitamin D deficiency or insufficiency should be corrected in all antiphospholipid antibody positive patients. So here's the 16th International Congress of Physicians on antiphospholipid syndrome on the primary thrombosis prophylaxis among APL positive carriers. So it recognized that patients with a clinically significant antiphospholipid antibody profile, they have increased risk for future thrombosis. Aspirin can be considered among asymptomatic antiphospholipid antibody positive carriers on a case-by-case basis. Hydroxychloroquine should be used in lupus patients with positive antiphospholipid antibodies. Due to limited data, statin cannot be recommended in the absence of other traditional cardiovascular disease risk factors. Vitamin D deficiency and insufficiency should be corrected in all antiphospholipid antibody positive patients. Now let's talk about secondary thrombosis prophylaxis, which is after a thrombotic events among antiphospholipid antibody positive patients. So those are the management of thrombotic APS patients. Current mainstay of treatment for thrombotic APS is heparin, followed by anticoagulation with the warfarin for life. Substantial debate has surrounded the intensity of warfarin therapy in patients with antiphospholipid syndromes. Observational studies in the 90s suggested that optimal anticoagulation regimen were those that maintain the INR between 3 and 4. However, 2 landmark trials in 2000s have shown otherwise. The first study is from McMaster University in Canada, led by Mark Crowther. So this is a randomized double-blind trials of 114 APS patients in which patients were assigned an INR of 2 to 3 or INR between 3 and 4. And they show that high-intensity warfarin was not superior to moderate-intensity warfarin for secondary thromboprophylaxis. And the second study is the WASP study, which came out in 2005. It is, again, a randomized control trial for 109 patients. They again showed that high-intensity warfarin was not superior to standard treatment and was associated with an increased rate of minor hemorrhagic complications. So based on the evidence of above two trials, the current standard of care for long-term management of thrombotic APS is still to maintain the INR between 2 to 3, particularly for venous thrombosis APS patients. While both studies included patients with arterial thrombosis, some experts in the field will argue that the number of arterial events and arterial thrombotic APS patients included in those two studies were too low to make any definitive conclusion for arterial thrombotic APS. Thus, in Europe, many doctors still treat APS patients with arterial events with a more intensive Coumadin target of 3 to 4 without baby aspirin. But here in America, we tend to target INR between 2 to 3, but we'll add baby aspirin for those APS patients with prior stroke. How about DOAC? Well, DOAC has been widely used in the prevention of venous thrombosis in hip and knee replacement patients, in treatment of PE, DVT, in treatment of AFib patients. Of course, observation studies in the past suggested that DOAC could be efficacious for secondary thrombosis prophylaxis among APS patients. And because those observational studies data, 4 randomized control trials were done to look at the efficacies of DOAC among APS patients. Unfortunately, all of those trials failed. All of them had negative results. The first one is a RAPS trial. This is an open-label prospective non-inferiority trial comparing 20 milligrams of rivaroxaban with warfarin. The primary outcome of this trial is actually not clinical, but rather percent change in endogenous thrombin potential, which is a parameter of thrombin generation. The result of this study did not meet its primary endpoint. The next trial is a TRAPS trial, which aimed to compare the effectiveness of rivaroxaban with warfarin among 120 high risk, which is triple positive antiphospholipid syndrome patients. And during interim analysis, 7 arterial events and 1 venous event occurred in the DOAC group, whereas none occurred in the warfarin group. So considering the excessive risk and no apparent benefits, this study was terminated early. Another rivaroxaban trial completed in 2019 in Europe also found a small increased risk of arterial thrombosis among rivaroxaban treated patients. The most recent trial was the Astro APS trial. It evaluated the efficacy of apixaban with Coumadin. Again, more stroke was found among apixaban treated APS patients, and study was terminated early. At this time, we do not have any randomized control trial data support the use of DOAC for thrombosis prevention in APS. So after these 4 randomized control trials, many academic societies, EULAR, ISTH, British Society of Rheumatologists, adjusted their guidelines regarding DOAC. So here I summarize their recommended approach. So DOAC should be avoided in APS patients with arterial thrombosis. DOAC should be avoided in triple positive APS patients. Well, warfarin should still be the first choice among those low-risk APS patients with venous thrombosis who's already been on DOAC and tolerated well and no events. And for those patients who cannot tolerate warfarin, then there may be a role to consider DOAC. Pregnancy management strategy of patients with a positive antiphospholipid antibody or APS are controversial. The recommendations are largely based on limited or low quality evidence and expert opinions. Here, I present the obstetric management consensus from 15th and 16th APS Congress and EULAR recommendations on 5 different obstetric clinical scenarios that you'll likely see in your clinic. So the first clinical scenario is when you have an antiphospholipid antibody positive woman who's pregnant but without any previous adverse pregnancy events, and also never had thromboembolic events in the past. The treatment recommendation for these patients is close monitoring of fetus and mother during pregnancy with the adding of aspirin. So the data supporting aspirin use largely come from studying of general high-risk pregnancy populations. Particularly in 2017, New England Journal of Medicine published an international randomized controlled trial of 1,176 women with high pregnancy risk. They showed that low-dose aspirin in women at high risk resulted in a lower incidence of preterm preeclampsia. I just want to point out their low dose is actually now 81 milligram. It's actually 150 milligram that were used in their trial. So, because of these data, the current recommendation for these type of women is still is adding aspirin and close monitoring. The second scenario is when you have a woman with positive antiphospholipid antibodies who does have a history of recurrent first trimester pregnancy loss. So the recommendation for this group of women is aspirin, and you can, consider adding prophylactic dose of Lovenox and heparin. And the recommendation for adding heparin and Lovenox is based on 3 low-quality randomized control trials. The first one was performed at UT Southwestern by William Kuta. It's a prospective single-center trial, included 50 antiphospholipid antibody positive women who were alternately assigned to aspirin plus heparin or aspirin alone. Aspirin plus heparin provides a significantly better pregnancy outcome than low-dose aspirin alone. The next study is from England by Ryan Hannah Cohen. It's a randomized controlled trial of 90 antiphospholipid antibody positive women with a history of recurrent first trimester pregnancy loss. It showed that treatment with the aspirin plus heparin leads to a significantly higher rate of live births. And the next one is from Goa. This is a trial out of India, also supports the addition of heparin and Lovenox to low-dose aspirin. However, you can see here, there are 2 other trials that did not show a significant benefit with the aspirin plus Lovenox treatments. And the first one is by Farquhar Hassans, done in 2002. And the second one was the HAPS-ASA trial out of Canada. This is a trial of 81 antiphospholipid antibody positive women, and no difference on live birth rate was found, whether you add the prophylactic Lovenox to baby aspirin or not. And here's a meta-analysis of all those trials. The cumulative results slightly favors aspirin plus prophylactic dose heparin or Lovenox treatment, but the confidence interval you can see barely crosses a significant line. And it's largely driven by the first 2 studies. And European colleagues still favors adding prophylactic dose of Lovenox for these type of patients. So the next scenario is when you have a antiphospholipid antibody positive women who have a history of ischemic placental mediated complications. These are the women who have a history of eclampsia or preeclampsia or late-term pregnancy loss. The recommendation for these patients is definitely give aspirin and definitely give a prophylactic dose of Lovenox or heparin. And this is based on 1 low-quality randomized controlled trials from Canada, and it included 110 antiphospholipid antibody positive women with a prior history of ischemic placental mediated complications. And they have shown that aspirin plus heparin and Lovenox associated with a lower rate of severe preeclampsia, also have a better, lower risk of a low birth weight. And the next clinical scenario is that if you have a antiphospholipid antibody positive women who have a history of thrombosis, so the recommendation for this scenario is that you need to give aspirin And here you have to give a therapeutic or high dose Lovenox or heparin. And this is based on one observational studies of 20 APS women with prior stroke. And this study has shown that treating these women with aspirin plus high dose Lovenox lowers the risk of preeclampsia and peripartum thrombosis. And the last one is postpartum management. So if you have an antiphospholipid antibody positive woman who never had any thrombotic events in the past, the recommendation is 6 weeks of Lovenox. And if you have a prior thrombotic APS, the recommendation is to start warfarin immediately. And this is, again, largely based on case control and cohort studies. And this is also the recent EULAR recommendations, also a Royal College of OBGYN's guideline from England. All right, now let's switch gear and talk about antiphospholipid antibody in COVID-19. So do COVID-19 patients get blood clots? Now, we all know, of course, they do. However, at the beginning of the pandemic, this was less clear. This is a quote at the early phase of the pandemic from the great professor Beverly Hong, who is a world-renowned expert in thrombosis from the UK. According to her, she had never seen such sticky blood. Well, she was right. After that, there were increasing reports of both arterial and venous thrombosis in patients with COVID-19. Of course, the histopathology of lung specimens from patients with severe disease showed not only characteristic findings of ARDS, but also evidence of fibrin-based occlusion of small vessels. And then this case report came out of the New England Journal of Medicine that really grabbed the attention of people in our field. This report described 3 Chinese critical ill COVID patients who had stroke, and they also found to have positive antiphospholipid antibodies. And after that, more and more reports of antiphospholipid antibody among COVID patients emerged, particularly among those severely ill patients. And when I was preparing this talk, I actually searched PubMed, and there are now over 1,738 papers on antiphospholipid antibodies in COVID-19 patients. This is a nice systemic review done by Professor Denis Wall from France. They analyzed 48 studies that reported the presence of antiphospholipid antibody among COVID-19. And so what they found is that lupus anticoagulant seemed to be more prevalent at 35 to 90% from various studies. And the presence of other antiphospholipid antibody, you can see here, was quite varied from study to study. Out of the 48 studies, 2 studies actually followed up antiphospholipid antibody persistence over time. The first study investigated the persistence of antiphospholipid antibody at 1 month and found only 1 out of 10 previously positive patients had persistent antiphospholipid antibodies. And the second study performed between 3 and 6 months after first positive lupus anticoagulant test found none had persistent lupus anticoagulant. So our group was also very interested in figuring out the presence and, most importantly, what are the functional role of those COVID-associated antibodies, antiphospholipid antibodies. So we set out to investigate antiphospholipid antibody in our cohort of hospitalized COVID-19 patients. This cohort was put together at the early phase of pandemic when steroids were not widely used. We found that more than half of those COVID patients had at least 1 antiphospholipid antibodies. And to our surprise, most prevalent antiphospholipid antibody found among COVID patients was not a well-studied one. It's actually the anti-PSPT IgG. Anti-cardiolipin IgM had the second highest prevalence, followed again by anti-PSPT IgM. When looking at the presence of antiphospholipid antibody at moderate to high titer, again, 30% of COVID patients had at least 1 positive antiphospholipid antibodies. We were most interested in evaluating the function of those antiphospholipid antibodies. So we purify those antiphospholipid antibody from COVID patients and inject those purified antiphospholipid antibody into a venous thrombosis mouse model. We use an electrolysis model where we introduce a small amount of direct current into the mouse blood vessels, and this activates the endothelium and turns on the clotting. And IgG isolated from patients with high levels of anti-PSPT IgG increase the thrombus length and weight. And to our surprise, low level of anti-PSPT IgG also potentiates thrombosis. So we confirmed our findings also in the stenosis venous thrombosis mouse model. Again, high anti-PSPT IgG in COVID patients, again, increase the thrombotic extension and accretion. Okay, so what triggers this COVID-induced autoimmunity that results in the production of antiphospholipid antibody and likely other antibodies? So I think it's likely a complex interplay between genetic predisposition, historical antigen exposures, and the hyperactivated host immune response in the setting of SARS-CoV-2 infections. Particularly, here's an important paper by Professor Ignazi Sang's group from Emory University. They found that severe COVID-19 patients tend to have a heightened atriofollicular B cell response, and many of them have similar B cell repertoire features that are seen in lupus patients. Thus, it is likely that these autoantibodies that we have seen in COVID-19 patients, including antiphospholipid antibody, may arise from a predominantly atriofollicular B cell response that is more prone to generating autoantibody secreting B cells. To support this theory, so I have measured BAFF, B cell activating factors, which promotes the differentiation of autoantibody secreting cells. We found a markedly elevated BAFF among those hospitalized COVID-19 patients, you can see here. All right, so here's some take-home message to summarize my talk. So I want you guys to recognize that antiphospholipid syndrome actually represents a disease spectrum. They can be quite heterogeneous when we see them in our clinic. Not every positive antiphospholipid antibody results is clinically significant. You want to make sure they are at the moderate to high titer, and we want to make sure they are persistently present for at least 12 weeks. And thrombosis is multifactorial, and primary thrombosis prophylaxis should take a risk stratified approach. Again, warfarin remains the treatment of choice for secondary thrombosis prophylaxis, among APS patients. DOAC should be avoided among arterial thrombosis APS patients, and also those APS patients with high thrombosis risk. Those are the triple positive APS patients. We should apply a patient-specific obstetric management strategies, as I summarized here in my talk. Antiphospholipid antibodies can present among critically ill COVID-19 patients, and they may be pathogenic. The true clinical significance of these COVID-associated antiphospholipid antibodies remains unknown. With that, that concludes my presentations. Thank you very much. Questions?
Thank you, Dr. Zhu, very much for that wonderful talk. I personally enjoyed it very much, and I'm sure the audience did as well. We do have some questions that have funneled through. One of which was basically asking, are all clots the same? Being if the patient has a positive APS labs, but they have a myocardial infarction or splenic infarct, would you anticoagulate them the same way?
So yeah, that's what I'm trying to show in my talk. Arterial thrombosis seems to carry more risk. Therefore, we like to anticoagulate much more aggressively. Again, we need to take a look at patient as a whole. I didn't talk about the microvascular thrombosis because this talk is mainly aimed at the first-year fellows. I don't want to complicate the pictures. Again, we have to understand as I talk the new insights into APS pathogenesis. This is actually a thromboinflammatory disease. a lot of manifestations such as microvascular thrombosis, such as patients with thrombotic microangiopathies. I will argue there's, in addition to anticoagulations, there's also a role of immunomodulatory agents, such as Rituxan, the mycophenolate. There's a very nice review by Duo Erkan from HSS. It's published last year in ANR, who talk about what we need to do for those microvascular APS patients. It's a nice read. You guys should check it out.
Great, thank you so much. And then another question that we have here is, what do you see coming up in the new guidelines for APS? You had mentioned some of the new antibodies, but do you think there are any big things that we should be looking for and thinking about when the new guidelines come out?
I don't know the details yet. Again, this is certainly myself hoping they can be inclusion of some of the newer antiphospholipid antibody. Particularly, I'm an advocate of anti-PSPT. Here at University of Michigan, me and Jason and I, we have an APS clinic here. We manage over 200 APS patients. We routinely test anti-PSPT. We do think that help us risk stratify our patients. Particularly, the value of those non-criteria antibody is those so-called seronegative APS patients. Those are the patients who have a traditional classic APS clinical manifestation, but their criteria antibodies, such as the anticardiolipin and beta-2-GP1, are persistently negative. So that could be a role of, using non-criteria antiphospholipid antibodies to help us risk stratify APS patients. So certainly I'm a big advocate, and but whether the guideline will include, I don't know. I'm definitely looking forward to that.
Great, thank you. Another question we have here is that if we should check antiphospholipid antibodies on every patient with a history of like preeclampsia or other pregnancy complications.
I think a patient with so here at University of Michigan, we work closely with our high-risk OB, and we got a lot of referral from them. This is definitely one of the things that our high-risk OB colleagues will test. That's one of their panels is check the antiphospholipid antibodies. And I don't have any data to suggest whether we need to test in all of them, but this is certainly something we do here at University of Michigan that our colleagues will do with the high-risk OB.
Great, thank you. And then another question we have here is somebody's talking about, first of all, they're thanking you for the very interesting talk, and then they wanted to ask you about a patient that they've had. They've had an APS patient with a couple of TIAs, both within 48 hours of having the COVID vaccine. Is there any evidence that vaccinations per se in COVID-19 specifically increase thrombotic events in these patients?
So I can say this, we have a position statement from APS Actions. Also, if you go on to APS Foundation of America, there's a consensus statement by international experts regarding COVID-19 vaccinations risk among APS positive patients. At this time, I can tell you we do not have any objective evidence to suggest that COVID-19 vaccination will potentiate thrombosis risk among antiphospholipid antibody positive patients. And we don't have any objective evidence that prevent our antiphospholipid antibody positive or APS patient, discourage them to getting COVID vaccines. So for us, as I say, we have managed over 200 APS and antiphospholipid antibody positive patients. Majority of our APS and APL positive patients receive vaccines, and all of them seems that they're doing well. Yeah, we don't have any objective evidence that receiving vaccine will significantly elevate the risk of thrombosis among APS patients.
Thank you so much, Dr. Zhu. Again, it was an excellent talk, and thank you for talking to all the audience today. For the attendees, there should be a quick survey. If you can complete that, there will be a QR code sent to you, I believe. And with that, I will pass it on to Dr. Dua for our next speaker, Dr. Kim. And thank you all for attending with us today.
Thank you. Bye.
All right. Hello, everyone. Thank you so much for joining us today and tuning in on the asynchronous videos for these amazing lectures. I am excited to introduce Dr. Kim. Dr. Kim is an adult rheumatologist at Barnes-Jewish Hospital, an assistant professor of medicine at Washington University School of Medicine, where he co-directs the Washington University Lupus Clinic. He runs a research program combining basic translational and clinical science approaches, focusing on the role of complement in lupus, social support erosion and its restoration for patients with lupus, and more recently, the immunogenicity and reactogenicity of the SARS-CoV-2 vaccination in immunosuppressed patients with immune-mediated inflammatory diseases. Dr. Kim is the president of the St. Louis Rheumatology Association, board member of the Lupus Foundation of America Heartland chapter, and a member of the Scientific Advisory Council that we're on together for the Rheumatology Research Foundation. I think most importantly, I met Dr. Kim during my fellowship, my first year at one of the RW meetings, and I think, and we're still friends today, so I think it's just important for all of you new fellows to take advantage of all the opportunities through ACR, to meet with your colleagues. You're gonna meet people who are gonna be leaders in the field and form really important friendships that will inspire your career. So I thank all of you for being here today. Oh yeah, I'm Anisha Dua. I'm at Northwestern. And I sort of launched this program, during COVID, and I'm really excited that it's still going on and doing so well. And all of you are joining the best specialty there is. So without further ado, Dr. Kim, welcome. Thank you so much for being here.
All right, thank you. Hello, everyone. Welcome to all the new fellows to rheumatology. I promise this will become the easiest, hardest thing you will ever do. Again, thank you, Dr. Duo, for the introduction to this lecture, and also the ACR Committee on Training and Workforce for the opportunity to introduce all of you to the impact of COVID-19 on rheumatic disease patients. So these are my disclosures, but none of them are relevant to this discussion. It's quite amazing that I can present everything to you on this outline, given that the first case of COVID-19 was identified only in December 2019. So just 2 years and 8 months later, under extraordinary clinical and societal stress, highly rigorous work has brought some meaningful level of understanding of the issues our immunosuppressed patients face with COVID-19, but also identified highly actionable approaches to mitigating this threat. So today we'll do a tour of COVID-19 and its intersection with rheumatic diseases, breaking the talk into 4 parts. First, we'll describe the outcomes of COVID-19 in patients with immune-mediated inflammatory diseases, focusing on the type of immunosuppressive class as a differentiating factor in outcomes. Next, we'll spend a good chunk of time describing the immunogenicity, the immune response to vaccination, and reactogenicity, the adverse events associated with vaccination of SARS-CoV-2 mRNA vaccines in patients with IMIDs. The data will focus on the mRNA vaccines, which the vast majority of our patients have received in US. Discussion on the benefits of additional dosing, along with emerging data on holding medications, will then occur, wrapping up with the discussion on reactogenicity. Guess what? These vaccines are safe for our patients. For those who just can't mount effective humoral responses to SARS-CoV-2 vaccines, we will then focus on probably the most important mitigating strategy for these type of patients: pre-exposure prophylaxis, or PrEP, using monoclonal antibodies. Very recent data has demonstrated how effective this strategy is for our heavily immunosuppressed. And finally, I'll wrap up with the discussion of multi-system inflammatory syndrome in both children and adults. This topic is really interesting and frankly confusing to me. So I hope you can, I can relay to you my appreciation of the work that's being done on this unusual phenotype of COVID-19. So let's go ahead and start off with COVID-19 outcomes in rheumatic disease patients. I think the first hint that people on immunosuppression may have worse outcomes from COVID-19 came from this early, very large study led by Ben Goldacre using the Open Safely platform in the UK. Over 11,000 deaths in the National Health Service hospitals linked to primary care data of 17 million adults using electronic health repositories was used to make the initial clinical identification of variables associated with death due to COVID-19. Many of the well-established variables that associate with worse COVID-19 outcomes were identified in the study, such as age, male sex, obesity, and disparities as seen on the slide. And also other comorbidities such as diabetes, cancer, chronic kidney disease, respiratory, cardiac, liver, and neurologic disease were first established using this data set. But you can see at the bottom of this slide are people with either RA, lupus, or psoriasis, which is next to other immunosuppressed conditions such as solid organ transplant patients, asplenic patients, those on chemotherapy for cancer, and others. These are fully adjusted point estimates that you see on the slide. You can see that people with RA, lupus, or psoriasis had a 19% increase in the hazard rate of death compared to those without these conditions. Similar observations were made by Kristen De Silva, Jeff Sparks, and Zach Wallace and their team using patients treated in the partners healthcare system. While death was not necessarily associated with having rheumatic disease, an association with severe COVID as defined by clinical need for mechanical ventilation or ICU care was observed with roughly a threefold increase. So just with these two data points, I think they collectively demonstrate that there is an increased risk of poor COVID-19 outcomes for patients with IMIDs that we treat. So while these early observations were being made, the COVID-19 Global Rheumatology Alliance was essentially magically formed in March 2020. It all started by a tweet by Len Calabrese on the upper right-hand corner of the slide here, who noted that in the inflammatory bowel disease world, they were starting a registry to characterize the impact of COVID-19 on these patients. Immediately, numerous discussion points were ongoing on Twitter, leading to the formation of the GRA under the leadership of Genius Yazdani at UCSF and Philip Robinson at University of Queensland, Australia. So within 48 hours of Len's tweet, the ACR had already provided their full support, and remarkably, within 2 weeks, the registry was up and running. This has been one of the most important efforts in understanding how COVID-19 impacts our rheumatic disease patients, along with those efforts from EULAR and other cohorts. So one of the first analyses from the GRA examined the risk factors associated with hospitalization from COVID-19. 600 cases collected within the first 4 weeks of the GRA registry are shown here. So things like age, cardiovascular disease, pulmonary, and renal comorbidities were confirmed to be problematic for our patients with IMIDs, while the use of moderate dose prednisone or higher increased the risk of hospitalization. Again, all of these variables are in blue boxes. While not statistically significant, you can also see that lupus patients also had this increased risk compared to RA patients, and that's in the red box. Also, surprisingly at that time, biologic and targeted synthetic DMARD therapies combined to one group actually decreased the risk of hospitalization by a little over twofold compared to those not on any DMARDs at the population level. Not shown here, but importantly, virtually all of this signal came from reductions. The reduction signal came from almost all of the people just on TNF inhibitors in further subset analyses. So now using death as an outcome measure, the GRA later published these analyses from over 3,700 cases collected until the end of June of 2020, adjusting for multiple variables that can influence COVID-19 outcomes listed on the left hand of the slide. You can see that age, to a certain extent male sex, and those with moderate to high disease activity all had increased odds of death. You can also see that various classes of immune-mediated diseases are separated by color here, with those who have connective tissue diseases having slightly higher odds ratios compared to other types of IMIDs. Now, here are the analyses based off of immunosuppressive medication. Now, using methotrexate as the reference, you can see that those not on DMARD therapy, those on sulfasalazine, on rituximab, and to a certain extent, those on 10 milligrams a day or higher prednisone, all had increases in the odds of death from COVID-19, with the largest risk coming from those on B-cell depleting agents. So another important analysis was examining a risk of severe COVID based off of biologic or targeted synthetic DMARD use, as these are generally more potent immunosuppressants than conventional DMARDs. Here, again, looking only at RA patients, those treated with either rituximab or JAK inhibitors both had increased risk of poor outcomes, with a fourfold increased odds of death or in mechanical ventilation for those on rituximab, and a twofold increased odds for JAK inhibitor users. This is just a tip of the iceberg of a large data set that has been collected over time, but summing up this large wealth of analyses, we can conclude that immunosuppressed patients with IMIDs are generally at increased risk of poor COVID-19 outcomes. Again, well-established comorbidities associated with poor COVID-19 outcomes also negatively influence outcomes in the immunosuppressed. And data I didn't show here, risk of infection did not increase. In other words, the acquisition of COVID-19 infection. This appears to be a function of just risk, exposure risk, rather than being immunosuppressed. We do know, though, that supraphysiologic doses of glucocorticoids, prednisone at 10 milligrams a day or higher, and or those with higher disease activity. Remember, these are intertwined with one another and are difficult to deconvolute. These are associated with higher hospitalization rates. Interestingly, I showed you earlier that those on biologic or targeted synthetic DMARDs are at lower risk of hospitalization. But when you look at the RA population on those type of medications, those on B-cell depleting therapies and JAK inhibitors are at higher risk of poorer COVID-19 outcomes, again, compared to those on TNF inhibitor therapies. In terms of mortality, though, B-cell depleting agents, the use of DMARDs and prednisone use greater than 10 milligrams a day are at increased risk of higher mortality compared to those people on monotherapy with methotrexate. Interestingly, and again, I mentioned this very briefly, sulfasalazine actually had a lower risk for reasons that are unclear to me. And again, on data that I'm not going to have time to present, disparities appear to also play a very substantial role. I was first introduced to this by some of the work that Shira Blazer had done, where she presented this work in lupus patients in New York City back in ACR 2020. And then most recently, there is data from the COVID-19 Global Rheumatology Alliance published just, I believe, last month, also describing this phenomenon. So let's go ahead and switch over to the impact of immunosuppression on vaccine-induced immunity. So by now, the risks immunosuppressed patients with IMIDs have of developing attenuated humoral responses following SARS-CoV-2 vaccination has been well described. This reference list in the bottom right only represents about 20% of the high-quality papers that have shown, most importantly, immunosuppressed people can generally mount decent acute antibody responses. And what I mean by acute is this is within the first week to 3 weeks post second dose of mRNA vaccination. The risk, though, is not uniformly distributed amongst the various immunosuppressive classes that our patients take. Rather, there is a clear hierarchy that has emerged, and not surprisingly, B-cell depleting agents, mycophenolate use, and glucocorticoid use confer the highest risk of poor acute antibody responses. So let's specifically discuss some of the few medication classes that appear to have substantial impact on human immunity, again, at least during the acute time frame post-vaccination. So glucocorticoid use was probably the most surprising subgroup, at least in our analyses, not because human responses were reduced, they were with a 9-fold reduction in antibody titers, but rather that some low-dose glucocorticoid users mounted very poor human responses, as seen on the right side here. So Laura Boekel's Dutch study and Julie Pak's effort at Johns Hopkins both found that prednisone monotherapy did not associate with poor responses. Rather, Julie's group found that it was those on concomitant immunosuppressive use, such as mycophenolate, that were the ones in the prednisone cohort with low antibody levels. So this highlights the work that still needs to be done to deconvolute the effect of multiple immunomodulatory and immunosuppressive medications and their association with antibody responses. Switching to antimetabolites here, mycophenolate or mycophenolic acid use was associated with a substantial 21-fold reduction in antibody levels compared to immunocompetent controls in our cohort, while methotrexate and azathioprine had more modest reductions. Notably, more detrimental impacts of methotrexate on antibody responses were observed in NYU Erlangen cohorts led by Jose Scher and Jörg Schett, along with Laura Boekel's group from the Netherlands, both of which are referenced here in the bottom right of the slide. Now, looking at biologic and targeted synthetic DMARDs commonly used, most of these had relatively modest effects on antibody titers. For example, TNF inhibitors in red was associated with a 2.3-fold reduction in antibody levels. Now, JAK inhibitors in blue had an 8.6-fold reduction, but everyone were able to seroconvert or had detectable antibodies, which is encouraging. But again, not surprisingly, B-cell depleting agents in light purple on the right was associated with dramatic decreases in seropositive rates and antibody titers, with nearly a 60-fold reduction in titers in our cohort. So we typically accept that it takes about 6 months for peripheral blood B cells to become detectable after rituximab administration. So it's been hypothesized that we have to wait that long to optimize vaccine responses. Several groups have data to suggest that this is probably right, but there's this meta-analysis by Matthias Moore's group from Bern University Hospital that provides additional support for this time cutoff. Here on the left, they did a meta-analysis. Admittedly, it's a small number of studies where antibody titers were published along with time from last dose of B-cell depleting therapy. Generally speaking, at least on the left side here, those who have at least a 6-month interval from last dose to vaccination, from 6-month interval from last dose of rituximab to vaccination appear to mount better humoral responses, again, seen on the left forest plot. On the right forest plot, this may correlate with the presence of peripheral blood B cells also. So this is actually consistent with some other observations. Thomas Dorner's group identified that the presence of peripheral B cells at a level of 10 cells per microliter best associated with human responses. And furthermore, it appears that the specific presence of peripheral naive B cells is particularly important, as demonstrated by another publication by Martin Strader's group in Austria. So the reductions in humoral immunity appear to translate to increased breakthrough infections in several studies. This is from the National COVID Cohort Collaborative, the N3C consortium, overseen by NIH and NCATS. And they published these observations derived from EMR data from a large, over 650,000 patient national sample of people who had received at least 1 dose of SARS-CoV-2 vaccine. So just focusing on the bottom part of the table boxed in red, which are those people who completed the initial series of mRNA vaccines, i.e. they got 2 doses. There was a general increase in susceptibility to breakthrough infections, both in the pre-Delta phase in the left columns, but also after Delta became the dominant variant in the US. And again, these were increased compared to immunocompetent controls. More granular data came from Jessica Whittafield's group from Sunnybrook Research Institute in Toronto. So her group used a test negative design to estimate vaccine effectiveness in those people with RA, angst-spawn, psoriasis, and IBD from the entire province of Ontario, Canada. They importantly only examined those with test results, as opposed to assuming that anyone with no results is negative. And this is to help reduce biases to patients with similar access to and indications for testing. So on the left, you can see the incidence of breakthrough infections following the initial series of mRNA vaccine, generally around 6% for these diseases. On the right, you can see the adjusted vaccine effectiveness in the last column, which is similar to what was reported in the phase 3 clinical trials for mRNA vaccines within immunocompetent individuals, generally in the 90%. So an important limitation of the study, though, is that this excludes diseases such as lupus or myositis, where more substantial immunosuppression, such as mycophenolate, is used more commonly. But I think, nevertheless, for this specific population of patients with IMIDs, this is very encouraging data and is consistent with the humoral data that we presented earlier. Now, there have been a lot of questions about whether to check antibody levels post-vaccination. I have been generally in the camp of not checking, largely due to the wide differences in testing platforms, and that the analyses demonstrate that neutralizing antibodies rather than total anti-S IgG antibodies, anti-S being anti-spike protein antibodies, are a much better surrogate for protection. So here's some actually analyses from the Dutch effort again, who've done just some wonderful work regarding SARS-CoV-2 vaccination. Here they examined over 5,800 participants and found that those people with higher anti-spike protein levels, and this is again to a very specific domain of the spike protein called the receptor binding domain, which contains the part of the spike protein that binds to the ACE2 proteins. So when you have antibodies against the RBD, you can block infection. This is what you observe as a neutralizing response in vitro. So for those people with higher RBD, anti-RBD antibody levels, they nearly had a 1.75-fold reduction in the odds of breakthrough infection compared to those with more modest levels of these antibodies. Okay, so you may ask yourself whether or not this type of data will make you check antibodies, okay? A nearly 2-fold decrease of breakthrough infection with higher antibody levels is what you are dealing with. And you also have to use their test to use their cutoffs that they've defined. Their test is actually a homebrew assay. It's not a commercial assay, but that's one that's created in someone's lab and it's been validated. So again, whether this extrapolates to the test that we can order, it's going to be really difficult. And still, in my mind, even considering these aspects and also these data, I still don't think it makes a lot of sense to check antibodies to me, at least right now. So given the reduction in human immunity that B-cell depleting agents, people on mycophenolate, mycophenolic acid, and glucocorticoid users have with the initial series of mRNA vaccines, the clear way to mitigate around this is through providing additional doses. Probably the most comprehensive report on this is in people with IMIDs, again, come from the Dutch. Here you can see antibody levels pre-vaccination, during and post-initial series of mRNA vaccination, and after receiving the third dose of mRNA vaccine. Generally speaking, most of these people were able to improve their antibody levels and maintain high levels. The major exceptions are those people on B-cell depleting agents, S1P inhibitors, which are used in multiple sclerosis, and a fraction of those on mycophenolate. But generally, again, these are very encouraging results and supports the need for additional doses for many of our patients. Another reason why to provide additional doses, I think this improves antibody quality. So when we looked at our cohort, we found that TNF inhibitor monotherapy users were completely unable to cross-variant neutralize beta nor delta variants, despite having good levels of total anti-spike IgG, and were still able to neutralize the common variant D614G, again, at the same time points as they were unable to neutralize beta or delta. Again, this is another reason why we shouldn't check antibody levels, as again, this could lead to misleading results. So the good news in our cohort was that the third dose really helped these TNF inhibitor users generate likely effective titers against both beta, that's in the middle column, the B.1.351, and the delta variants, that's going to be the B.1.617.2 on the right. So again, this confirms the necessity to provide additional doses to our IMID patients. There are other data from Julie Pock's Hopkins effort. There are 2 case series that their group has published in Annals of Rheumatic Disease that also highlights this point, although they report from a total anti-spike protein antibody titer perspective. I do want to bring up data from the solid organ transplant experience, as this continues to emphasize the need for getting additional doses. So those with who have solid organ transplants are on substantial immunosuppression. Most of these patients mount to very poor antibody responses because they are on calcineurin inhibitors, steroids, mycophenolate, and mTOR inhibitors. So generally speaking, after the initial series of mRNA vaccines, using Dori Segev's data from his cohort at Hopkins, 46% of solid organ transplant patients mounted 0 responses. They had undetectable antibodies. Once they get a third dose, this number reduces to the mid-30s% in several studies. But worrisomely, over half of the people with no response after 2 doses still had no response after 3 doses. So this brings us to data from France presented here. In those people with antibody levels lower than the threshold predicted to correlate with the presence of neutralizing antibodies, and this is shown in the dotted line at around 150 BAU per mil, you can see that 50% of these participants who were below the threshold following 3 doses now had levels above that threshold with the 4th dose of vaccine. So I think this brings up a critical point, particularly for those at high risk of poor responses, say in this case, those on mycophenolate, mycophenolic acid, or calcineurin inhibitors. We really need to try to push them to get that 4th dose. Even within the solid organ transplant space, you can get poor responders who are to be able to generate probably effective antibody responses with that 4th dose. Now, having said that, let me contradict myself just a bit. The most vulnerable population, those on B-cell depleting agents, were studied through the Norwegian Norvac cohort led by Ingrid Jensen. All of these study participants had rheumatoid arthritis, and they looked at post-third dose antibody titers rates in those with poor or no response after the initial series of mRNA vaccine. As you can see here on the left figure, the vast majority of these type of people still had poor absent antibody titers after the third dose. Now, statistically, they report that most of the responders following the third dose were about 8 months out from their last rituximab dose, compared to the non-responders, which are generally 6 months out. This doesn't really pass the eye test when you look at that violin plot, so I'm not sure if this is indeed true. But again, our B-cell depleted agents, B-cell depleted patients who don't respond well to the initial series of vaccine may not have substantial benefit with at least a third dose. More studies regarding the timing from the last B-cell depleting dose, also with the fourth dose, are really needed though. So let's have a brief discussion about holding medications. Data are just starting to emerge about this with the SARS-CoV-2 vaccines. We know that from a Korean study that holding methotrexate for 2 weeks after influenza vaccine results in higher antibody titers compared to those that do not hold, hence its recommendation. Somewhat similar data was obtained by the vacuuming study in Berlin, where RA patients with minimal or no disease activity held at least 1 dose of methotrexate, either as monotherapy or with concomitant medication known not to influence antibody titers, such as leflunomide, IL-17 inhibitors, IL-12/23 inhibitors. And they were held for at least 1 week for either dose or both doses, compared to those people that didn't hold methotrexate for both doses. In this particular study design, as you can see in the dot plots, there were improvements in those people who did hold. And here, what's on the y-axis is a surrogate virus neutralization tested against the common variant of a spike protein. Of those who didn't hold their meds, and shown in the middle dot plot, the biggest risk factor mounting low antibody responses were those people with an age of 60 or greater. Similar data from Julie Pak's effort and colleagues at Hopkins, this time with mycophenolate, was also shown, and they demonstrated that holding mycophenolate did improve to a certain extent the ability to circumvert post-vaccination with the initial series of mRNA vaccines. So, again, these data are just starting to emerge, and maybe there's some justification to hold meds. But again, you will have to probably just do this in those people with low or no disease activity. Flares are clearly at a risk here. And so as a result, shared decision-making will be critical in holding meds or not, particularly if you're going to have, these 2 or 3 dose series of vaccines. There is a formal study examining this, sponsored by the NIH, NIAID, the ACV01 study. Some of you may be at sites that are participating, and if so, reach out to the site PI or co-investigators to get details and also help provide some possible participants in this study. So we'll wrap up this section with a discussion of reactogenicity. So multiple studies, including data published by Monica Yang at UCSF shown here, have confirmed the safety and reactogenicity of mRNA vaccines in patients with IMIDs. Generally speaking, on the left side here, the types and severity of adverse events are similar to those who are immunocompetent. Interestingly, on the right side here, Monica was able to show, at least in our cohort, relationships between the severity or type of adverse events with antibody levels. Furthermore, additional studies have shown minimal risk of disease flare. For disease like RA or lupus. Generally, flare rates occur in the single digits percent-wise. Overall, though, I think the take-home point is that multiple studies have confirmed the low risk of harm in these patients. So to summarize this complicated section, most people with immunosuppressed patients with IMIDs will mount acute antibody responses. Those at the greatest risk, B-cell depleting therapies are by far the biggest threats. Those on mycophenolate, the second biggest threat, and then you also have glucocorticoid users. Most everyone else, maybe a modest exception of JAK inhibitors, are kind of lumped together. Again, JAK inhibitors are probably the worst out of this group. And again, all of these are slightly worse than those who are immunocompetent. Those on B-cell depleting therapies likely will need to wait at least 6 months from the last dose prior to any vaccine to optimize responses, not just SARS-CoV-2 vaccines. And again, providing additional doses can break through in a good way the block in human immunity mediated by the immunosuppressive medications. But there's an exception with B-cell depleting agents. It just seems like that those people with poor responses seem to have later on durable poor responses. Holding medications can improve antibody titers. I do have also questions about whether or not this can optimize antibody quality or this cross-variant neutralization. Again, the ACV-01 trial will help answer some of these questions. The SARS-CoV-2 vaccine is safe. It's comparable in severity and the types of symptoms compared to immunocompetent controls, along with a low risk of disease flare. So when you have these type of discussions with patients who are hesitant, I think we can confidently make these statements. And again, at least in our cohort, we did find correlations between the amount of reactogenicity and the level of immunogenicity. So, there's a new vaccines that are coming around the corner, including those from like Sanofi GSK, which is a protein subunit vaccine. So this is a spike protein plus an adjuvant. This is similar to the hepatitis B vaccine that's available now. Normally, just FYI, this can be used for additional doses of boosting. Obviously, it's too new to for any additional discussion, but it does bring up the idea of heterologous vaccination. In other words, you get, say, mRNA vaccine in the first series and maybe even third dose, but then you switch over to a protein subunit vaccine for the fourth dose. This is a really new topic, and I think it's fascinating because the type of adjuvants used in these vaccines are going to be different. Whether or not this translates to improved immunogenicity and therefore improved protection remains unknown, though. And of course, finally, Omicron-specific mRNA vaccines will be launched next month. This should be effective in more rapidly diversifying antibody responses to Omicron subvariants. I'm going to make an assumption that I'll be recommending this particular type of vaccine to all of my patients unless something worrisome pops up. Okay, so let's switch over to PrEP, or pre-exposure prophylaxis, in this case in COVID-19 with monoclonal antibodies, as this is really a game changer, particularly for our B-cell depleted patients. So the drug is called Evishield, a brand name. The two antibodies that make it up is called tixagevimab and silgavimab. These are two monoclonal antibodies, both of IgG1 kappa, with high affinity to different epitopes on the spike protein. So both can bind at the same time. And in that situation, the dissociation constant is in the low picomolar range. This is very high affinity for protein-protein interactions and even for antibody-protein interactions. Most antibodies bind to their protein in the nanomolar range. This is at least 100 times tighter. So there's a very high affinity antibody to spike protein. 300 milligrams of each antibody is administered separately in intramuscularly gluteally. A key feature of these two antibodies is that the Fc domain has been modified, so its half-life is triple. Remember, most IgGs have a half-life around 4 weeks. Here, because of these modifications, the half-life is much longer. It's nearly 3 months. So the combination of its long half-life with its high affinity to spike protein really allows it to generate a long period of protection for people that are unable to mount effective responses. And as a result, you're able to dose this every 6 months. The EUA from the FDA was granted for use as PrEP back in December of 2021. Just to review, for use in patients, this is for use in patients greater of 12 years of age or older, weighing 40 kilograms or greater. It has broad indications for use, and this is intentional. Even people that you think mounted good responses but are who are immunosuppressed, they are most likely eligible for this type of vaccine, or I mean for this therapy. You have to remind the patients, though, that they have to have a good faith effort to get vaccinated. Generally speaking, we are requiring, at least in our center, our patients to have completed at least 3 doses of vaccine. They have to have a very good medical reason why either they have never been vaccinated or they can't get the second or third dose of vaccine. In the second scenario, it's usually because they've had adverse events or flared because of the mRNA vaccine. So the type of people that are eligible are listed here. Again, these are actually all just taken from the FDA EUA for Evishield. And again, I put the link down in the bottom here. Focus on the last bullet point. So these are the people that are eligible for Evishield. People on high-dose corticosteroids, 20 milligrams of prednisone or a day or greater, or an equivalent, given for at least 2 weeks. Antimetabolites, tumor necrosis factors, or other biologic agents that are immunosuppressive or immunomodulatory. This is really broad. I think there's only 2 classes of patients that we typically treat with IMIDs that probably may not qualify. Those on hydroxychloroquine monotherapy and apremilast monotherapy. Everyone else, though, is eligible. And again, to highlight this point even further, there is no utility of antibody testing here. If they're just on these medications, they are eligible to receive it as long as they've made a good faith effort to get vaccinated. So now there are encouraging reports describing how Evishield is effective in our immunosuppressed population. The first report came out last month by Cassie and Len Calabrese and their colleagues at the Cleveland Clinic, where they analyzed patients who were on B-cell depleting therapies, they were vaccinated against SARS-CoV-2, and also had a breakthrough infection. So looking at the severity of breakthrough infection, people who received Evishield had an impressive reduction in breakthrough COVID-19 disease severity. So in those who did not receive Evishield, just over 50% of these people with breakthrough infections required hospitalization, including 17% that required mechanical ventilation or ECMO or had died. This is compared to 0% in those who received Evishield. Now, these data are largely from the Delta wave, but wow, regardless, this is really compelling evidence of the effectiveness of Evishield in the highest risk population. Similar observations were made in an Israeli cohort, this time from the Maccabi Healthcare Services, which is the second largest HMO in Israel. They broadly examined those people with any immunosuppressive condition. Some of those are listed in the bottom left side of the bottom left table on the slide. Impressively, those who received Evishield were 92% less likely to be hospitalized or die compared to those who didn't receive Evishield. And importantly, no deaths were recorded in the Evishield group. Furthermore, specifically looking at those who received B-cell depleting therapies, a 60% reduction in SARS-CoV-2 vaccine, 60% reduction in SARS-CoV-2 infection was observed in those people who received Evishield. So collectively, these data really strongly support the use of prophylactic monoclonal antibody administration and Evishield in our patients with IMDs who qualify. I didn't present this, and there's a lot of chatter and concern about this. For example, Evishield has an 8-fold reduction in neutralization capacity against the Omicron subvariants. When you work out the stoichiometry, you still have plenty of antibody to be able to likely protect and neutralize against those the Omicron subvariants. So I think we'll continue to see the effectiveness of Evishield even within the Omicron period. I can't think of a reason why patients with IMIDs who qualify should not get Evishield. They should, and again, within the FDA EUA restrictions. I'm quite surprised, and the same thing with Len Calabrese, who's been very active and vocal on Twitter and also on Helio about the kind of the lack of awareness of Evishield. I want you guys to be able to lead the effort to educate other rheumatologists and other providers who take care of immunosuppressed patients to be able to provide Evishield for these patients. Okay, so let's go ahead and wrap up with a discussion of multisystem inflammatory syndrome that has been observed primarily in the pediatric population in the COVID-19 pandemic. So I have to agree with the words of Daniel Reif and Randy Cron at UIB that this is maybe the biggest surprise to me about COVID-19. By the way, this review in the upper left-hand corner here is a really nice introduction for fellows to start your understanding of MIS-C. So this syndrome was first published back in early May 2020. A group from the UK described 8 children with symptoms consistent with Kawasaki's disease, a rare vascularized, primarily involving medium-sized muscular arteries, primarily affecting those of Asian ancestry. In these children in the UK series, symptoms including fever, rash, conjunctivitis, GI manifestations, which then proceeded to a high output shock state with low peripheral vascular resistance, requiring hemodynamic support was observed. In this series, most 6 out of 8 children actually were SARS-CoV-2 PCR negative, but 4 of these 6 negatives had close relatives with confirmed or suspected COVID-19. Worrisome to me, though, was the lack of prodromal symptoms prior to the onset of this presumed Kawasaki-like disease. Then in the following week, a group from Bergamo, Italy, described 10 children fulfilling either complete or incomplete diagnostic criteria for Kawasaki disease during the initial outbreak of COVID-19 in the region. Again, most of these children had negative SARS-CoV-2 testing, but clearly there appeared to be an association with COVID-19. So when you look at the incidence of those fulfilling either incomplete or complete diagnostic criteria Kawasaki disease, there was this unusual 30-fold spike in 2020 with a disproportionate number of cases that were severe. Remember, Kawasaki disease is rare. It's only 12 to 30 per 100,000 children younger than 5 years old. So seeing a spike in numbers like this has to force your thinking into a novel etiology for this phenotype. So again, the group from Bergamo did some further analysis, and they found additional laboratory differences that made this spike in the Kawasaki-like disease unusual in the region. So here they have two different groups. Group 1, which represents those who met criteria for Kawasaki disease prior to COVID-19, while Group 2 are meeting those criteria once the COVID-19 pandemic hit that region. You can see reductions in total white blood cell count. Lymphocytes and platelets were noted in Group 2, along with elevations in most patients of ferritin. Additionally, more patients in Group 2 had symptoms consistent with Kawasaki disease shock syndrome, KDSS. They also met a Kobayashi score of 5 or greater, which is a risk scoring system predicting non-responsiveness to IVIG therapy. And more people in this group required glucocorticoid therapy. Interestingly, half of these people also fulfilled criteria for macrophage activation syndrome. And many of the children in shock also appeared to have something similar to a cytokine storm syndrome. What made this more likely associated with COVID-19 was that 8 out of 10 patients in Group 2 likely eventually circumverted for IgM or IgG against the nucleocapsid of SARS-CoV-2, as you can see in the table on the bottom of the slide. This, along with native SARS-CoV-2 PCR testing, suggests to me that this could be a possible post-infectious process that's occurring. So I mentioned the diagnostic criteria for Kawasaki disease. So for completeness sake, they're listed here on the left side of the slide, just pulled from up to date. You know, we associate Kawasaki disease through the serious manifestation of coronary artery aneurysms, usually detected by TTE, but this is largely absent in people with MIS-C. So there are these differences that now are apparent that can distinguish Kawasaki's disease from MIS-C, and they are listed on the bottom right-hand of the slide. The children with MIS-C are generally older. They appear to have a different race ethnic predisposition. They have more severe presentations along with changes in qualitative symptoms, including fever, GI manifestations, and more myocarditis rather than a coronary artery aneurysm. So with these differences in mind, the CDC and World Health Organization presented case definitions for MIS-C. I'm not going to go through them in any details. These are self-explanatory, but realize that those with the Kawasaki-like disease presentation or any pediatric death associated with COVID-19 should also have MIS-C considered as an etiology. Realize that MIS-C is still a rare complication of COVID-19. It's certainly less than 1% of pediatric COVID-19 cases. And based on data from New York State, confirmed SARS-CoV-2 infection in those younger than 21 years old were 322 out of 100,000, while MIS-C was only 2 out of 100,000. So a task force assembled by the ACR also published their own diagnostic algorithm shown here. Again, I won't go through this in any detail, but I think this nicely accounts for the hematologic and other lab abnormalities that were first described with the MIS-C cohort in Bergamo, which is a plus compared to the CDC and World Health Organization case definitions. So a similar phenotype was observed in adults with SARS-CoV-2 infection. This is termed MIS-A. Two of the earliest reports are cited here, one led by the CDC and one from Icahn School of Medicine at Mount Sinai. MIS-A was typically observed in young adult males, but it maintained the fever, GI symptoms, cardiac symptom complex, along with a disproportionate number of cases with severe disease requiring ICU care for hemodynamic support. Importantly, what distinguishes MIS-A from severe COVID in adults is the general absence of respiratory compromise in MIS-A. Furthermore, consistent again with MIS-C, those with MIS-A appear to have this lag between the SARS-CoV-2 infection and development in MIS-A. Most of these people are still going to be PCR negative. And then again, there's this mismatch in terms of peaks of MIS-A and COVID-19 peaks. They tend to the MIS-A and MIS-C peaks lag about a month behind the COVID-19 case peaks. So again, I'm going to bring this up again. This makes me wonder whether or not this is a post-infectious process that's ongoing. So the treatment of MIS-A is largely based off what's been effective for Kawasaki's disease. And interestingly, this has worked out. This is again from the ACR task force, and their guidance suggests that IVIG with glucocorticoids are now the first line treatment, with IL-1 inhibition, high-dose glucocorticoids, or infliximab being second line. You'll read some reviews that will favor IL-1 inhibition over TNF inhibition due to the rapid kinetics of clinical efficacy and favorable risk-benefit ratio that's observed with IL-1 inhibition. There's also some data with IL-6 inhibition, but as you can see, it has not made it into the guidance. So to summarize MIS-C, older pediatric age, fever, GI manifestations, and non-coronary aneurysm cardiac manifestations can be used to distinguish MIS-C from classical Kawasaki disease. Several hematologic and other laboratory manifestations are also noted in MIS-C, and a hyperinflammatory milieu contributes to this vasoplegic shock that's also unique to MIS-C. I was just in a meeting with Hermine Brenner from Cincinnati Children's right before this, and she reminded me about this last point here, that the Omicron variant seems to have reduced the severity of MIS-C, and we hope that this trend continues. MIS-A appears to be similar to MIS-C, but is concentrated in young male adults. They use the lack of significant pulmonary involvement as a distinguishing feature from severe COVID-19. Immunosuppression is key for treatment. IVIG and glucocorticoids are first line. And one thing I haven't mentioned is the pathophysiology, as this is just starting to be worked out. Several groups have been working on this. I'm just highlighting work from Ed Barron's work group at CHOP, who used a proteomic approach to identify phospholipase A2 group 2A as a biomarker of MIS-C, particularly in those people with severe endotheliopathy due to thrombotic microangiopathy. In addition, dysregulated responses to gamma interferon, similar to macrophage activation syndrome, was also observed. Although strangely, in their analyses, they actually found that those people with elevated gamma interferon actually required less inotropic support. So given the similarities with macrophage activation syndrome / HLH, and this is a disease associated with defects in genes important for perforin-mediated cytolytic pathway used by CD8 positive T cells and NK cells, there also appears to be some of these same gene defects that may be associated with development of MIS-C. This table on the bottom right is from another Wonder review by Randy Cron, which is referenced at the bottom. Nevertheless, we are still in the very early stages of understanding this bizarre complication of COVID-19. Okay, so we covered a ton of stuff, but I'm going to briefly leave you with these final thoughts. First, will it ever get better for our patients? I'm going to direct you to this patient published last week from the Sparks-Wallace Consortium, where they noted a reduction of severe COVID-19 cases in those with IMIDs during the Omicron period. I left a tweet in the upper right here from Jeff Sparks with possible reasons why this may be when the preprint dropped a couple months ago. Of course, this is good news, but only time will tell whether this trend will continue as the cat and mouse game between our immune systems and SARS-CoV-2 evolution plays on. Next, long COVID is something that's been a very confusing topic to me. Just last week, Kiku Iwasaki's group published a really pretty amazing preprint describing the global immune signatures in the blood of patients with long COVID, with a weird finding that the best association with long COVID was low cortisol levels. Definitely something to follow over the next several months or so. Finally, I think we will see a surge in referrals to our clinic with post-COVID autoimmunity. If you're not aware, a hallmark of COVID-19 is the production of autoantibodies. Certainly within the rheumatic disease realm, you just heard Ray Zhu, excellent presentation, who, along with Jason Knight at Michigan, described their exceptional work looking at the acquisition of antiphospholipid syndrome antibodies in COVID-19 patients, contributing to their coagulopathy. And again, Ray discussed it. Naki Sen's work, who's the chief of rheumatology at Emory. His group has demonstrated that COVID-19 is associated with this B cell activation pathway called the extrafollicular response. Again, Ray mentioned this, rather than germinal center response. And again, to reiterate, these EF responses appear to be responsible for generating autoantibodies in both lupus and COVID-19. So all of this may translate to an acquisition of a post-COVID autoimmune disease. And recently, I have seen several case reports of inflammatory myopathies emerging post-COVID. So again, another story to keep a close eye on. So with that, I really appreciate your attention, and I'm free to answer any of your questions. Thanks.
Thank you so much, Al. That was a fantastic presentation covering so much information. For the people on here, if you can fill out the poll questions that are popping up on your screen, that would be great. So I know that trying to keep up with this information has been super challenging for anyone. So I'm glad that you were able to do that and provide all that information for us. A couple of questions that have come through. So patients, I know at the beginning you were talking about patients on belimumab versus rituximab and risks of mortality. So one question was, for the patients on belimumab, which we know is B-cell depleting, they seem to have a lower mortality risk compared to rituximab. And can you explain any thoughts on why there might be a difference there in terms of the mechanisms of the drug?
Yeah, this is a really interesting point. I didn't bring this up specifically, but I believe it was Manuel Gartegil, along with the COVID Global Rheumatology Alliance, that published this earlier this year. So just as a kind of recap, they did an analysis in systemic lupus erythematosus patients of risk factors associated with different COVID-19 outcomes, and they did indeed find that belimumab had a reduction, I believe it was about a twofold reduction in severe COVID-19 outcomes. And I guess, you know, to me, I'm not 100% sure why that is. You know, I can't even begin to speculate. I think what's fascinating is that, at least in our cohort and a couple other cohorts, when you vaccinate people on belimumab, their antibody levels are actually really low. So this is very confusing because this actually makes the argument that in the setting of belimumab, you're going to create low antibodies, yet at the same time, somehow this is protective, at least partially a twofold reduction in like hospitalization. Again, I think there's going to be a lot of work, and maybe it has to do with these EF responses and potentially the generation of autoantibodies. Again, we'll see how this all plays out within the next year. But I would say that, again, if I give you this talk in a year, this is going to be a very different talk.
Fair enough. Okay, great. Another question for you. And it's a little bit on a separate topic. So how much should we be pushing for our patients to receive antiretroviral therapy when they get COVID?
Yes.
Given many of them have this immunocompromised status, what are you doing with that?
Yeah. So patients with rituximab who have a breakthrough infection or are just infected, I think generally I will give them Paxlovid. There's a lot of discussion about Paxlovid breakthrough, whether it's a phenomenon that's unique to Paxlovid. It seems like there's a preprint that dropped a few weeks ago that showed that breakthrough is actually relatively common, even in people who don't take Paxlovid. You know, again, yeah, this is a kind of a different topic in terms of management of immunosuppressed people once they get COVID-19. And some of this is going to be dictated by hospital policy. You know, as an outpatient, you can get Paxlovid, but it's somewhat difficult to get therapeutic monoclonal antibodies unless you're hospitalized, at least within our system. You know, your part of this is hoping that even though they had received rituximab and got COVID-19, that they'll do okay. So again, in those cases, I'll definitely give Paxlovid. But again, if they start to decompensate and require hospitalization, then everything else kicks in based off a hospital protocol. Here, they'll get monoclonal antibodies and additional therapies if needed.
Okay, great. So staying on the rituximab line, I know it's amazing, and I know a lot of my patients have benefited from the fact that you have so much less hospitalization now that Evusheld is approved for those rituximab patients and other patients. But do you have sort of thoughts on a recommended stepwise treatment for patients on rituximab? So are you holding doses? Are you giving them Paxlovid? Do you think we're just going to be doing monoclonal antibodies Q6 months into eternity, or what's your thoughts on a—
Yeah, so at least in my lupus patients, the majority of my patients refuse to stop rituximab. Again, lupus offers an interesting perspective because it takes years for them to get their diagnosis. It takes some time to find the right mixture or type of therapies that will control their disease. So they're really hesitant to change once they find something successful. So in these patients, we've continued their rituximab based off of kind of their original dosing schedule. I don't necessarily do every 6 months. Usually most of my patients are every 9 to 15 months, which gives us an opportunity to be able to vaccinate within the windows where we think their B cells are popping back. But also we do give them Evishield regardless. So definitely we'll be doing both. We give them rituximab, we'll give them Evishield. Sometimes we even do them on the same day, just to make sure that even though they may be 12 months out, we're not going to take the risk, and we'll just give them the Ritux and Evishield together. But yeah, I think that's kind of for certainly mycophenolate users and rituximab users, doing Evishield for all of them is going to be something we'll do at least for the short term.
Okay, and kind of tied in with that, do you think that the discrepancy in B cell depletion risk is disease specific? So you were just talking about lupus patients. Do you think that they might have a different risk from ANCA patients, for example?
That's an interesting question. I'm not aware of subset analyses looking at specific diseases in terms of B cell depletion. Most US cohorts may not be able to answer that. Potentially Julie Pox Hopkins cohort, because they're really large. The Dutch and Israeli efforts might be able to answer that. I'll have to look back to see if people reported that. I'm not aware of any data though. Specifically. This is going to be somewhat complicated by other concomitant medications, but eliminating that, I'm not sure if there's a clear answer right now.
Okay. There's just questions just keep coming through. So is there any evidence of increased risk of flares? I know you're talking a little bit about how the flares are usually not super mild, and you're still recommending holding the doses, holding some of the immunosuppressive medications if possible. Is there an increased risk with like more and more vaccines? So, if you get 4 vaccines versus 2 or 3, I know it's becoming a little bit more difficult in conversations with patients to convince them. Some patients are happy to get vaccinated every day, but others, you have to sort of convince them this next dose is needed. And is there an increased risk of flares with that? And
that's another good question that we're not really clear with. We have an answer to. Again, anecdotally in our experience, we have not necessarily seen it, but this is a little bit self-selecting, right? So people who have flare tend to not to get the additional doses. So again, anecdotes, not data, plural anecdotes, not data. I keep saying this, I feel like in a lot of my talks. And so it will be interesting, but again, I'm not sure how we control study design wise for kind of a self-selecting dropout. So again, it's a great question with an unclear answer.
And then when, I know there's been some conversation about like using for folks who get the vaccine and then also get the infection and they are better protected. Can you speak to that a little bit? Why?
Yeah. This hybrid immunity concept is really interesting. And this is what I was kind of hinting at with a heterologous vaccination. And we don't know necessarily the answer why people with hybrid immunity seem to have more outstanding or more optimized humoral responses. But the adjuvants are going to be different between the SARS-CoV-2 virus and say the mRNA vaccine. The SARS-CoV-2 virus is going to have endogenous adjuvants like the RNA in and of itself that could tickle either TLR7/8, Reg-I, Sting, a whole bunch of different intracellular sensors. But the mRNA vaccine, its adjuvant is lipids, so it's going to kind of tickle a different aspect of the immune system. So I don't know the reason why hybrid immunity seems to have a higher ceiling in terms of optimal responses. But again, it does bring up this interesting question for the future about whether or not we should be thinking about mixing the adjuvants as we provide additional doses or boosters in order to, again, increase the ceiling of our optimal responses. It's a really interesting hypothesis.
Great. And here's the last one. Why do you think that 3rd dose helps with getting a cross-variant response in like those TNF users that you were mentioning?
Oh, such a good question. So I think It all has to do with memory B cells. So one of our collaborators on Coveripad, Ali El-Abedi, and there are numerous other investigators, Shane Crotty, et cetera, that have all shown that the germinal center response that you get with vaccination is absolutely critical to optimizing antibody responses. And so it does this through mostly somatic hypermutation. Each time a B cell divides into germinal center response, it changes one of the nucleotides in its antigen binding region, which then allows it to diversify. The naive B cells that come into germinal center response and early germinal center responses have a relatively low level of somatic hypermutation, but they can still differentiate into, say, memory B cells. Now, germinal center responses with mRNA vaccines last a very long time in humans, at least 7 months. So what ends up happening is you generate memory B cells early, then they get re-recruited back into the germinal center responses. And it's actually those memory B cells that come back to the germinal center responses that explode the diversity of antibody responses. So with the 2 doses, you're going to have of mRNA vaccine, you're going to have 7 months of germinal center responses. Then it potentially will quiet down. Then you get another jab, which then takes the entire pool of memory B cells, and you're going to generate new GC responses, which then diversify the antibody response even more. So this then allows you to generate a really diverse catalog of antibodies, that are capable of a cross-variant neutralization. So all of us that are not immunosuppressed, who've gotten at least 3 doses, we have a huge catalog of antibodies that are most likely going to be able to neutralize variants that haven't even been created yet, let's just say. So again, this is our body's way of trying to anticipate future threats by just overwhelming it by numbers.
Awesome. Well, I think our time is up. That was super interesting. And thank you so much for teaching us so much today.
Absolutely, my pleasure.
Oh, yes. And next, be sure to tune in for the next session. But it's actually our last section of the VIP series, and that will be on Thursday, 10:30 to 12:30 Eastern time. And the topics are going to be case-based immunology for rheumatologists by Dr. Mazen Nasrallah and reproductive health by Joanne Zell. So thanks again.